Join us at the 2025 ASCO Gastrointestinal Cancer Symposium from January 23rd through 25th in San Francisco or online. Learn the latest innovative science and solution-focused strategies and make connections in the global GI cancer community. Register at gi.asco.org today.
Hello, I'm Dr. Ryan Augustin, your guest host of the ASCO Daily News Podcast today. I'm a medical oncology fellow at Mayo Clinic in Rochester, Minnesota. Joining me today is Dr. Jason Luke, an associate professor of medicine and the director of the Cancer Immunotherapeutic Center at the University of Pittsburgh Hillman Cancer Center. I had the privilege of working as a postdoc in Jason's translational bioinformatics lab, where we investigated mechanisms of resistance to immunotherapy in melanoma and other cancers. Today, we'll be discussing three important topics, including neoadjuvant immunotherapy and the importance of multidisciplinary team coordination, the impact and practical considerations for incorporating TIL therapy into melanoma, and the current and future use of CD3 engagers in both uveal and cutaneous melanoma. You'll find our full disclosures in the transcript of this episode. Jason, it's great to have this opportunity to speak with you today.
Absolutely. Thanks, Ryan. It's great to see you.
So to kick things off, Jason, we of course have seen tremendous advances in cancer immunotherapy, not only in metastatic disease, but also the perioperative setting. Recent data have shown that the use of neoadjuvant therapy can provide not only critical prognostic information, but can also help individualize post-resection treatment strategies and potentially even eliminate adjuvant therapy altogether in patients who achieve a pathologic complete response. This signifies a conceptual shift in oncology with the goal of curing patients with immunotherapy. In triple-negative breast cancer, the KEYNOTE-522 regimen with pembrolizumab is standard of care. In non-small cell lung cancer, there are now 4 FDA-approved chemo-IO regimens in both the neoadjuvant and perioperative settings. And of course, in melanoma, starting with SWOG 1801 utilizing pembro monotherapy, and now with combined CTLA-4 PD-1 blockade based on results from the NADITA trial, neoadjuvant IO is the new standard of care in high-risk resectable melanoma. It's important to highlight this because whereas other tumor types have more mature multidisciplinary care, for example, patients with breast cancer are reviewed by the whole team in every center, and every patient with lung cancer certainly benefits from multidisciplinary care conferences. That's not always the case with melanoma, given the relative frequency of cases compared to other tumor types. Jason, would you say that we have now moved into an era where the integration of a multidisciplinary team in melanoma needs to be prioritized? And why is it important to have multidisciplinary team coordination from the onset of a patient's diagnosis?
Well, I think those are great questions, Ryan, and I think they really speak to the movement in our field and actually the great success that we've had integrating systemic therapy, particularly immunotherapy, into our treatment paradigms. And so before answering your question just directly, I would add even a little bit more color, which is to note that over the last few years, we've additionally seen the development of adjuvant therapy into stages of melanoma that historically speaking, were considered low risk, and medical oncologists might not even see the patients. And to that, I'm speaking specifically about the stage 2B and 2C approvals for adjuvant anti-PD-1 with pembrolizumab or nivolumab. So this has been an emerging sort of complication. Classically, patients are diagnosed with melanoma by either their primary care doctor or a dermatologist. And again, classically, the next step was referral to a surgeon who would remove the primary lesion with discussion around nodal evaluation as well. And that paradigm's really changed now, where I think integration of medical oncology input early on in the evaluation of the appropriate treatment plan for patients with melanoma is quite a pressing issue now, both because we have FDA approvals for therapeutics that can reduce risk of recurrence, and whether or not to pursue those makes a big difference to the patient for discussion early on. And then moreover, the use of systemic therapies now prior to surgery, of course, requires the involvement of medical oncology. And just for an emphasis point on this, it's classically the case for good reason that surgeons complete their surgery and then feel confident to tell the patient, well, we got it all and you're in really good shape. And while I understand where that's coming from, that often leaves aside the risk of recurrence. So you can have the most perfect surgery in the world and yet still be at very high risk of recurrence. And so it's commonly the case that we get patients referred to us after surgery who think they're just in totally good shape, quite surprised to find out that, in fact, they might have a 20 to 50% risk of recurrence. And so that's where this multidisciplinary integration for patient management really does make a big difference. And so I would really emphasize the point you were making before, which is that we need multidisciplinary teams of med-onc with derm, with surgery early on to discuss what are the treatment plans going to be for patients. And that's true for neoadjuvant therapy. So for palpable stage 3, where we might give checkpoint inhibitors or combinations before surgery. But it's true even in any reasonably high risk melanoma. And I would argue in that stage, anything more than stage 1 should be discussed as a group, because that communication strategy with the patient is so important from first principles so that they have an expectation of what it's going to look like as they are followed out over time. And so we're emphasizing this point because I think it's mostly the case at most hospitals that there isn't a cutaneous oncology disease management meeting. And I think there needs to be. It's important to point out that usually the surgeons that do this kind of surgery are actually either the GI surgeons who do colon cancer or the breast surgeons. And so, given that melanoma, it's not the most common kind of cancer, it could easily be integrated into the existing disease review groups to review these cases. And I think that's the point we really want to emphasize now. I think we're not going to belabor the data so much, but there are enormous advantages to either perioperative or adjuvant systemic therapy in melanoma. I mean, we're talking about risk reduction of more than 50%, 50 to 75% risk reduction. It's essential that we make sure we optimally offer that to patients. And of course, patients will choose what they think is best for their care, but we need to message them to them in a way that they can understand what the risks and benefits of those treatments are, and then, are well set up to understand what that treatment might look like and what their expectations would be out over time. So I think this is a great art of medicine place to start, instead of belaboring just the details of the trial, to say, let's think about how we take care of our patients and how we communicate them on first principles so that we can make the most out of the treatments that we do have available.
That's great, Jason. Very insightful points. Thank you. So shifting gears now, I'd also like to ask you a little bit about TIL therapy in melanoma. So our listeners will be aware that TIL is a promising new approach for treating advanced melanoma and leverages the power of a patient's cytotoxic T cells to attack cancer cells. While we've known about the potential of this therapy for some time, based on pioneering work at the NCI, this therapy is now FDA approved under the brand Amtagvi from Iovance Biotherapeutics, making it the first cellular therapy to be approved for a solid tumor. Now, I know TIL therapy has been administered at your institution, Jason, for several years now under trial status, primarily for uveal melanoma using an in-house processing. But for many cancer centers, the only experience with cellular therapy has come under the domain of malignant hematology with CAR T administration. At our institution, for example, we have only recently started administering TIL therapy for melanoma, which has required a tremendous multidisciplinary effort among outpatient oncology, critical care, and an inpatient hematology service that has expertise in cytokine release syndrome. Jason, where do you see TIL therapy fitting into the metastatic space? Which patients do you think are truly candidates for this intensive therapy? And what other practical or logistical considerations do you think we should keep in mind moving forward?
Well, thanks for raising this. I think the approval of lifileucel, which is the scientific name for the TIL product that's on the market now, it really is a shift, a landscape shift in oncology. And we're starting in melanoma again, as seems to be commonly the case in drug development. But it's really important to understand that this is a conceptually different kind of treatment, and therefore it does require different considerations. Starting first with data and then actualization, maybe secondarily. When we see across the accelerated approval package that led to this being available, we quote patients that the response rate is likely in the range of 30%, maybe slightly lower than that, but a meaningful 25 to 30% response rate. And that most of those patients that do have response, it seems to be quite durable, meaning patients have been followed up to 4 years and almost all the responders are still in response. And that's a really powerful thing to be able to tell a patient, particularly if the patient has already proceeded through multiple lines of prior standard therapy. So this is a very, very promising therapy. Now, it is a complicated therapy as well. And so, you highlighted that, to do this, you have to have a tumor that's amenable for resection, a multidisciplinary team who has done a surgery to remove the tumor, sent it off to the company. They then need to process the TIL out of the tumor and then build them up into a personalized cell product, bring it back. You have to lymphodeplete the patient, reinfuse this TIL. So this is a process that in standard of care setting under best circumstances takes roughly 6 weeks. So how to get that done in a timely fashion, I think is evolving within our paradigms. But I think it is very important for people who practice in settings where this isn't already available to realize that referring patients for this should be a strong consideration, and thinking about how you could build your multidisciplinary team in a way to be able to facilitate this process, I think is going to be important, because this concept of TIL is relevant to other solid tumors as well. It's not approved yet in others, but we kind of assume eventually it probably will be. And so, I think thinking through this, how could it work? How do you refer patients is very important. Now, coming back to the science, who should we treat with this? Well, of course, it's now a air quotes standard of care option. So really it ought to be available to anybody. I will note that currently the capacity across the country to make these products is not really adequate to treat all the patients that would want. But who would we optimally want to treat? Of course, would be people who have retained a good performance status after first line therapy, people who have tumors that are easily removable, and who have not manifested a really rapid disease progression course, because then, of course, that 6-week timeline probably doesn't make sense. The other really interesting data point out of the clinical trials so far is it has looked like the patients who got the least amount of benefit from anti-PD-1 immunotherapy, in other words, who progressed immediately without any kind of sustained response, those patients seem to have the best response to TILs. And that's actually sort of a great biomarker, right? So this drug works the best for the population of patients where checkpoint inhibitors were not effective. And so as you think about who those patients might be in your practice as you're listening, I think prioritizing it for primary progression on anti-PD-1, again, and giving that a head thought about how would you get the patient through this process or referred to this process very quickly is really important, because that lag time is a problem, right? Patients who have melanoma tend to progress reasonably quickly, and 6 weeks can be a long time in melanoma land. So thinking ahead and building those processes is going to be important moving into the future.
Definitely appreciate those practical considerations, Jason. Thank you. Moving on to our final topic, was hoping to discuss the use of immune cell engagers in melanoma. So similar to CAR T therapy, bispecific T-cell engagers, or BiTEs as they're commonly known, are standard of care in refractory myeloma and lymphoma. But these antibodies engaging CD3 on T cells and a tumor-specific antigen on cancer cells are relatively new in the solid tumor space. Tarlatamab, which is a DLL3 and CD3 bispecific antibody, was recently approved in refractory small cell lung cancer. And of course, tebentafusp, an HLA-directed CD3 T-cell engager, was approved in uveal melanoma in 2022. Both T and NK cell engaging therapies are now offering hope in cancers where there has historically been little to offer. However, similar to our discussion with TIL therapy, bispecifics can lead to CRS and neurotoxicity, which require considerable logistical support and care coordination. Jason, I was wondering if you could briefly discuss the current landscape of immune cell engagers in melanoma and how soon we may see these therapies enter the treatment paradigm for cutaneous disease.
So I think it is an exciting, novel treatment strategy that I think we will only see emerge more and more. You alluded to the approval of tebentafusp in uveal melanoma, and those trials were over the course of a decade, where those of us in solid tumor land learned how to manage cytokine release syndrome, or the impact of these C3 bispecifics, in a way that we weren't used to. And what I'll caution people is that CRS as this term, it sounds very scary because people have heard of patients that, of course, had difficult outcomes in hematologic malignancies, but it's a spectrum of side effects. And so when we think about tebentafusp, which is the approved molecule, really what we see is a lot of rash, because GP100, the other tumor antigen target, is in the skin, so patients get a rash. And then people do get fevers, but it's pretty rare to get more than that. So really what you have to have is the capacity to monitor patients for 12 hours, but it's really not more scary than that. So it really just requires treating a few people to kind of get used to these kinds of symptoms, because they're not the full-on ICU level CRS that we see with, say, CAR T cells. So, but where is the field going? Well, there's a second CD3 bispecific called brenetafusp, excuse me, that targets the molecule PRAME, that's in a phase 3 clinical trial now for frontline cutaneous melanoma. And tebentafusp is also being evaluated in cutaneous melanoma for refractory disease. So it's very possible that these could be very commonly used for cutaneous melanoma, moving into, say, a 2 to 4 year time horizon. And so therefore getting used to what are these side effects, how do you manage them in an ambulatory practice for solid tumor, et cetera, is going to be something everyone's going to have to kind of learn how to deal with. But I don't think it should be something that people should be afraid of. One thing that we've seen with these molecules so far is that their kinetics of treatment effect do look slightly different than what we see with kind of more classic oncology therapies, these drugs have a long-term benefit, but doesn't always manifest as disease regression. So we commonly see patients will have stable disease, meaning their tumor stops growing, but we don't see that it shrank a lot. But that can turn into a very meaningful long-term benefit. So that's something that we're also as a community going to have to get used to, is it may not be the case we see tumors shrink dramatically up front, but rather we can actually follow people with good quality of life over a longer period of time. Where is the field going? You mentioned tarlatamab in small cell lung cancer, and I think we're only going to see more of these as appropriate tumor antigens are identified in different tumors. And then the other piece is these CD3 engagers generally rely upon some kind of engagement with a T cell, whether CD3 engagers, and so they can be TCR or T cell receptor based therapies, or they can be also SCFV based. But that then requires new biomarkers because TCR therapy requires HLA restriction. So understanding that now we're going to need to profile patients based on their germline in addition to the genomics of the tumor. And those two things are separate. But I would argue at this point, basically everybody with cutaneous melanoma should be being profiled for HLA-A201, which is the major T cell receptor HLA haplotype that we would be looking for, because whether or not you can get access immediately to tebentafusp, but for clinical trials would become more and more important. Finally, in that T cell receptor vein, there are also T cell receptor transduced T cells, which are also becoming of relevance in the oncology community. And people listening will be aware in synovial sarcoma of the first approval for a TCR transduced T cell with afami-trezgene autoleucel. And in melanoma, we similarly have TCR transduced T cells that are coming forward in clinical trials into phase 3, the IMA203 PRAME-directed molecule particularly, and leveraging our prior conversation about TILs, we're going to have more and more cellular-based therapies coming forward, which is going to make it important to understand what are the biomarkers that go with those, what are the side effect profiles of these, and how do you build your practice in a way that you can optimally get your patients access to all of these different treatments, because it will become more logistically complicated kind of as more of these therapies come online over the next, like we said, 2 to 4 years kind of time horizon. So it's very exciting, but there is more to do both logistically and scientifically.
That's excellent. Thanks, Jason. And thank you so much for sharing your great insight with us today on the ASCO Daily News Podcast.
Well, thanks so much for the opportunity.
And thank you to our listeners for your time today. You will find links to the abstracts discussed today in the transcript of this episode. And you can follow Dr. Luke on X, formerly known as Twitter, at JasonLukeMD, and you can find me at Ryan Augustin, MD. Finally, if you value the insights that you hear on the ASCO Daily News Podcast, please take a moment to rate, review, and subscribe wherever you get your podcasts.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.